Hello, everybody, and welcome to our poster session on Synergizing Health Interventions for Toronto Gay and Bisexual Men, or the SHIFT project, increasing HIV prevention access and capacity through task shifting. We're excited to be presenting our findings today. The people involved in this project are myself, Maxime Charest from U of T, Dane Griffiths, Barry Adam, John Maxwell, Aaron Turpin, Keith McCready, and Robin Ahmed. The background of the study is that we've known that researchers identified the importance of community-based aid service organizations in promoting health and well-being among GBM. So task shifting, which is the delegation of clinical tasks to unregulated paraprofessional community workers, can serve to increase access to services and reduce the burden on licensed professionals. This is an idea that came from the World Health Organization in looking at how to shift some tasks around resources when there are less clinical resources available in a certain context or community. And we're seeking to apply it here in Toronto. So the aim of the study was to examine service delivery options that could increase access to HIV STBBI testing, PrEP, and non-clinical mental health assessments and care among GBM in Toronto through coordinated service delivery between community workers and clinicians. We had 33 interviews with our participants. 19 of them were clinicians and 14 were community workers. All of the interviews were conducted over the phone or Zoom since the onset of COVID-19. Clinicians included physicians, HIV specialists, nurses, social workers, psychologists, psychotherapists, and a pharmacist. Community workers came from the ASOs serving GBM around the city of Toronto, and also other organizations that were exemplifying task shifting opportunities outside of Toronto. Demographics of the clinicians are that the average age was about 41, 9 with a master's degree, 5 with a different professional degree, and 6 with a different kind of level of education. For gender, options were man, woman, genderqueer, trans, and so we had basically identities where people selected of the clinicians, 16 identified as men and 3 identified as women. In terms of sexual orientation, because our numbers are relatively small, we're not able to identify the exact numbers for specific identities. But in terms of sexual orientation, either 14 of our clinicians identified as gay. Some of the categories under other are straight, queer, or bisexual. And this is true also in terms of race and ethnicity. So 12 of the clinicians identified as white, and 8 identified as some of the other categories, which included South, East, and Southeast Asian, Middle Eastern, Latin American, Black African, First Nations, Indo-Caribbean, and mixed. And so those same mix of categories falls for the community workers as well. The community workers were a little bit younger, slightly different levels of education, 7 with a college or university degree, 5 with a master's degree, and 2 with another level of education. Again, 10 identified as men and 4 identified as other than man. So it could, again, that could be genderqueer, woman, or trans. Same for sexual orientation, and same in relationship to race. 6 of the participants identified as white, and 8 of them identified from one of the racial ethnic identities. So the overall response to the concept of task shifting during our interview process was that most participants seemed to be supportive of some form of task shifting. Community workers were generally in far more favor of task shifting, though this varied based on the service that was discussed. Clinicians had more mixed responses towards task shifting, especially when they involved controlled acts that required regulatory approval like drawing blood or psychotherapy. So overall, it was a positive interaction, more so for the community workers than the clinicians. In terms of our three areas, the first one being HIV STI testing, there was a sense among the participants that rapid testing could and should be performed by community workers. There were some concerns from clinicians around community workers giving a diagnosis of HIV. So if someone had a positive test or they were diagnosed positive by the test, that of course has regulatory concerns. And so that came out through the interviews with our clients. Some community workers had already been trained in rapid testing and even in phlebotomy, and there were more mixed messages regarding any kind of drawing of blood or genital and anal swabs, of course, more invasive procedures. So a community worker here says, I'm interested in doing point of care. It's something that would not be a chore to me. It wouldn't be like, oh my God, there's this extra thing I have to do. It's like, no, I would be so stoked to do this because this is my area of interest. In terms of home and self-testing, community workers reported having an important role to play in educating and supporting clients around testing and potentially in performing home and self-testing. So especially in allaying clients' fears and anxieties. So couldn't it be possible that we have an opportunity to do testing in settings where there are community organizations for clients to obtain and perform the self-testing, but to have the staff or community workers ready and available to support them as they're going through the process. So a community worker here said, now for clinicians, I think they would be important to provide the more scientific or medical support, but that's not needed in every case. People need a lot of time to sit down and really address some of the anxiety we have around HIV, and a frontline person, not a clinician, would be more suitable for that position because they have more experience working with particular populations. In terms of PrEP, so the first was testing, the second is PrEP, the third is mental health. In terms of PrEP, community workers talked about the possibility of performing pre-counseling for PrEP and potential follow-up visits, as long as a healthcare provider interpreted the required tests, of course, prescribed the medication and was available for consult if needed. They could also provide additional support around adherence, system navigation, and course management, cost management. One of the quotes from a clinician was, you have like a team of 3 people working together. One's a nurse, a physician, one's a community worker of some sort, and they're all in the same place. In every visit, people come and they go through in a rotary system to see all 3 providers, and maybe there is a way to streamline that so you can get PrEP delivered very, very efficiently to many, many people. In terms of mental health, conversations around mental health were much more complex. There's a need to think about mental health much more broadly than psychotherapy. Participants raised multiple concerns and issues where community workers could play a key role, like around issues related to drug use or loneliness, or particular communities such as Black, Indigenous, or other people of color who are gay and bi guys. So could we think about mental health a little bit more upstream and a little more broadly? So a clinician states, I think we would have to overhaul the whole model, really. And I think frontline folks could have a huge role in that. A lot of people want to do groups, drop-in programs. Those don't need to be run by licensed healthcare providers. Often it's just a space for people when they need something at that time. Some of the impacts of COVID were that this has had a wide-ranging impact on the work of clinicians and community workers. Several services were moved to online. Some were closed down briefly or dramatically reduced service delivery. Hours were reduced and such. Concerns about the accessibility of testing services in PrEP, and some partnerships and collaborations with clinicians and community workers were halted because of the pandemic, such as testing inside community offices. So there seems to be a lot of support among clinicians and community workers for some form of task shifting. Services that seemed most feasible were rapid testing and support with home self-testing. Potential benefits included cost effectiveness, the community workers' ability to reach a more diverse cross-section of the gay and bi guys community, and the building of trust and communication between clinicians and community workers. Our next steps in this process is to work with clinicians and community workers to develop an implementation plan in the City of Toronto for at least one new tool, service, or program as a result of this. So we'll be gathering for a day to have a chance to do that. These are the references from the project, and this is my contact information. Thank you so much for viewing our presentation.